blood is important in regulating pH and transport of oxygen, nutrients, carbon dioxide, and wastes. Maintaining the integrity of the circulatory system is crucial to life. When injury to a blood vessel occurs, hemostasis is initiated. Hemostasis is a process to stop bleeding. Hemostasis has three mechanisms. First, vasoconstriction to reduce blood flow through the injured area. Second, aggregation of blood platelets at the site of injury to create a physical plug. Third, aggregation of fibrin into an insoluble clot that covers the rupture and stops loss of blood. Today, we will cover 5 topics. First, we will start with activation of platelets. The primary factor that activates platelets is collagen. Collagen binds the GP1A2A complex on platelets. GP1A2A is a transmembrane protein of the integrin family. GP1A2A serves as a receptor for collagen. Binding of collagen to GP1A2A activates platelets. Activated platelets release thromboxane A2 from membranous zone. Fibrinogen and van Willebrand factor from alpha granules. ADP and serotonin from delta granules. Van Willebrand factor promotes adhesion of platelets to endothelium. Fibrinogen promotes aggregation of platelets. Van Willebrand factor binds both collagen and platelets simultaneously. Here is van Willebrand factor. It binds collagen on one side and GP1B in complex with GP5 and GP9 on platelets on the other side. This promotes platelet adhesion to the endothelium. Second, van Willebrand factor protects factor VIII. It stabilizes factor VIII and prevents it from being degraded. Third, after activation of platelet, van Willebrand factor can bind GP1B on the one side and GP2B3A on platelets on the other side. This promotes platelet aggregation. Van Willebrand factor is produced by endothelium and alpha granules of platelets. Both thromboxane A2 and ADP increase expression of GP2B3A, whereby they promote platelet aggregation. In addition, thromboxane A2 also promotes vasoconstriction. In summary, van Willebrand factor promotes platelet adhesion. Thromboxane A2, ADP, platelet activating factor, and fibrinogen promote platelet aggregation. Serotonin produced by enterochromaffin cells in the GI tract is stored in platelets. When platelets are activated, they release serotonin. Serotonin promotes vasoconstriction. Now, let's move to part 2. We will look at activation of coagulation. Coagulation is a process to generate fibrin. Fibrin strands strengthen the physical plug made by platelets. This picture shows red blood cells enmeshed in fibrin clot. This picture shows regularity of a fibrin fiber under an electron microscope. The first step in coagulation is activation of proteases. It is extracellular matrix and membrane proteins that serve as a receptor for various zymogens and protein cofactors. It is on the matrix proteins and on platelets where zymogen and cofactors are activated. Ultimately, the final blood clot is formed by conversion of fibrinogen to fibrin. There are two activation pathways. One is extrinsic, the other one is intrinsic pathway. That all leads to activation of factor 10 protease, which in turn activates the thrombin-catalyzed production of fibrin. Both pathways share two proteases. One is factor 10 and the other one is thrombin. If we start with 100 molecules of factor 7, each activated factor 7 cleaves 100 molecules of factor 10. Each activated factor 10 cleaves 100 molecules of prothrombin. Each thrombin cleaves 100 molecules of fibrinogen. Then at the end, we will get over 1 million of fibrin molecules rapidly. This amplification cascade model explains how blood clots are formed rapidly. Second feature of this process is regulation of zymogen enzyme. Factor 12, 11, 10, 9, 7, and 2 are zymogens of serine proteases. Cleavage of zymogen leads to an active protease that activates another zymogen. These zymogens are regulated by a series of non-protease cofactors. Two important cofactors are factors 5 and 8. This table summarizes all proteases and cofactors in coagulation. In particular, 5 zymogens and 1 protein cofactor are highlighted. They all contain GLA residues. The intrinsic pathway involves factor 8, 9, 11, and 12 in 2 complexes. The core protein complex is comprised of factor 8, 9, and 10. Activated factor 9, highlighted here, cleaves factor 10. This complex is controlled by factors 11 and 12. The intrinsic pathway begins with formation of primary complex on collagen. It is comprised of high molecular weight kilinogen, prekallikrein, and factor 12. Kallikrein cleaves factor 12. Activated factor 12 cleaves factor 11. Activated factor 11 cleaves factor 9. The extrinsic pathway involves tissue factor, factor 7 complex. Tissue factor is also known as factor 3. It is a transmembrane protein expressed by cells which are normally not exposed to flowing blood, such as subendothelial cells and cells surrounding blood vessels. Tissue factor, factor 7 complex, cleaves factors 10 and 9. One way to make it easier to remember this complex is using a simple math. 3 plus 7 equals 10. It represents factor 3 and factor 7a complex cleaves factor 10. This pathway can release thrombin far more quickly than intrinsic pathway because it acts on factor 10 directly. The last complex in coagulation is prothrombin factor 10A complex, also known as prothrombinase complex. It consists of prothrombin, factor 10A, factor 5A, calcium, and phospholipids. Factor 10A cleaves prothrombin to its active form, thrombin. Thrombin then cleaves fibrinogen. Fibrinogen is a large fibrous protein that contains two sets of tripeptide units. Each of these is one tripeptide unit. It consists of alpha, beta, and gamma chains. Thrombin cleaves four small peptides in the middle region of fibrinogen. After release of these small peptides, fibrin monomers can now aggregate to form soft clot of fibrin. Among these four small peptides released, two are from cleavage of alpha chains, and the other two from beta chain. These small peptides are enriched of negative charged amino acid residues, aspartic acid, glutamic acid, and sulfated tyrosine residues. Removal of peptides increases affinity of fibrin monomers. Four coagulation factors, factors 2, 7, 9, and 10, along with protein C and protein S, contain carboxyglutamate residue or GLA residue. This modified amino acid residue binds calcium with a high affinity. Binding calcium brings this protein close to platelet surface for their action there. Here I use one mnemonic to summarize these proteins. 1972 Creative Suite. It represents factor 10, factor 9, factor 7, factor 2, along with protein C and protein S. Synthesis of GLA residues results from post-translational modification of newly synthesized proteins in the liver ER by a vitamin K-dependent carboxylase. Binding calcium brings these proteins close to platelet surface for their action there. Vitamin K-dependent carboxylase converts glutamate to gamma glutamate residue. At the same time, vitamin K is oxidized to vitamin K epoxide. Vitamin K epoxide needs to be recycled. Recycle of vitamin K epoxide is catalyzed by vitamin K epoxide reductase and vitamin K reductase. Warfarin and dicumarol are anticoagulants. They are competitive inhibitors of vitamin K epoxide reductase. This is vitamin K. Warfarin and dicumarol are analogs of vitamin K. These drugs inhibit formation of GLA residues of 6 proteins that I described to you earlier. Specifically, blocking of GLA modification by drugs prevents secretion of newly synthesized proteases. Here is the liver. When vitamin K is available, proteins are gamma carboxylated and secreted. When vitamin K is not available, these proteins are not gamma carboxylated and not secreted. The soft clot of fibrin monomers is stabilized by cross-linking. This is similar to cross-linking in collagen. Here is integration with collagen synthesis. Both processes involve lysine, but different from collagen. Cross-linking of fibrin occurs between glutamine and lysine residues. It is catalyzed by transglutaminase. Cross-linking between glutamine and lysine residues generates isopeptide bonds. Here is an isopeptide bond. Now, let's move to part 3. We will look at inactivation of coagulation. If the activated thrombin was not regulated, the fibrin clot could continue to form and eventually block circulation. There are two main ways to inactivate coagulation. First is using anti-proteases. They are protease inhibitors. They bind specifically to the activated serine proteases. Second is using a negative feedback mechanism through protein C and protein S. These two proteins inactivate factors 5 and 8. Antithrombin 3 is a protease inhibitor that tightly binds and inactivates thrombin. Heparin promotes association between antithrombin 3 and thrombin. As a result, heparin has been used as an anticoagulant. Thrombin forms a complex with an endothelial cell receptor, thrombomodulin. In the presence of thrombomodulin and calcium, thrombin cleaves protein C to its active form. Activated protein C uses protein S as a cofactor to cleave and inactivate factor 5 and factor 8. Both protein C and protein S contain GLA residues, as described earlier. When an injury occurs, tissue factor and factor 7A form a complex with factor 10. In this complex, factor 7A cleaves factor 10 into its active form. Factor 10A forms a complex with factor 5A and prothrombin. In this complex, factor 10A cleaves prothrombin into its active form. Thrombin, in complex with thrombomodulin, cleaves protein C into its active form. Activated protein C, in complex with protein S, cleaves factor 5A into its inactive form. By a similar mechanism, activated protein C cleaves factor 8A into its inactive form. Here is a summary of inactivation of coagulation. Activation of the blood coagulation involves the site-specific, rapid amplification and activation of factors that quickly generate the fibrin clot. Since the activation is localized to the site of injury, formation of fibrin clots should not be occurring throughout the entire circulatory system. This is achieved by the combination of anti-proteases and protein C. Now, let's move to part 4. We will look at fibrinolysis, a process to dissolve blood clots. Fibrinolysis involves two proteases. One is plasmin, as shown here, and the other one is TPA. Plasmin is the serine protease that degrades fibrin clot. TPA cleaves plasminogen into its active form, plasmin. TPA stands for tissue plasminogen activator. TPA binds with a high affinity to the fibrin clot, along with plasminogen. In this complex, TPA converts plasminogen to plasmin. Plasmin then digests fibrin. After plasmin degrades a region of clot, the resulting digested peptides dissociate from the clot and take plasmin TPA complex away with them. TPA is then inhibited by plasminogen activator inhibitors, or PI. Plasmin is inhibited by antiplasmin. This information is summarized in this slide. Serine protease inhibitors include Pi1 and Pi2 for TPA, and alpha-2 antiplasmin for plasmin. Now, let's move to part 5. We will look at coagulopathy. Coagulopathy, or a bleeding disorder, is a condition in which the blood ability to form clots is impaired. Causes of bleeding disorders may include dysfunction or reduced levels of platelets, genetic mutations that cause a deficiency in clotting factors, or use of anticoagulants such as warfarin, coumarin, and aspirin. For lab tests, we typically measured prothrombin time, or PT, and activated partial thromboplastin time, or APTT. To measure PT, tissue factor is added to the plasma. Therefore, PT evaluates the extrinsic pathway. To measure APTT, phospholipids and activators are added to the plasma. APTT evaluates the intrinsic pathway and common pathway of coagulation. Here are two reagents that we need to be aware of. Thromboplastin is a laboratory reagent. It contains tissue factor and phospholipids. Partial thromboplastin contains only phospholipids. To measure PT, calcium and thromboplastin are added to the sample and then measure the time required for fibrin clot formation. To measure APTT, calcium, partial thromboplastin, and activators are added to the sample. Van Willebrand disease is caused by a deficiency in van Willebrand factor. Patients with van Willebrand disease typically have bleeding from mucocutaneous sites, such as skin and mucous membranes, rather than from deep tissues and joints. For diagnosis, we can measure the amount or the functionality of van Willebrand factor. Here, I'm going to show you ristostatin-induced platelet agglutination assay. The antibiotics ristostatin promotes binding of van Willebrand factor to GP1B on platelets. Recall, van Willebrand factor can also bind platelets at GP2B 3A. Therefore, when ristostatin is added to normal blood, it causes agglutination of platelets. Hemophilia A, B, and C are caused by deficiency in factors 8, 9, and 11 respectively. Hemophilia A and B are X-linked recessive, and hemophilia C is autosomal recessive. Factors 9, and 11 are produced in the liver. Factor 8 is produced by liver sinusoidal cells and endothelial cells in the peripheral tissues throughout the body. Patients with hemophilia A or hemophilia B have internal or external bleeding episodes. Bleeding may occur anywhere in the body. Some of the more serious signs of bleeding are joints, muscles, digestive tract, and the brain. In severe cases, bleeding may be spontaneous. Patients with hemophilia C have similar symptoms, but they do not have bleeding into joints. They do not bleed spontaneously. Hemorrhages tend to happen after a major surgery or injury. Lab tests for hemophilia A, B, and C show normal PT and a prolonged APTT. Recombinant proteins have been used to treat hemophilia A and B. Plasma-derived factor 11 concentrate has been used to treat hemophilia C. Factor V Leiden thrombophilia is caused by a missense mutation in the factor V gene. The mutation causes factor V to be inactivated at a slower rate. Patients with factor V Leiden thrombophilia have a poor anticoagulant response to activated protein C and an increased risk for venous thromboembolism. When a clot forms in a deep vein, typically in the leg, it is called a deep vein thrombosis. If the clot breaks loose and travels to the lung, it is called a pulmonary embolism. For diagnosis, two APTT tests are run simultaneously. One test is run in the presence of activated protein C, and the other one without. A ratio of APTT results from these two tests provides evidence for diagnosis. There's no cure for this disorder yet. Treatment is focused on prevention of thrombotic complications using blood thinners such as heparin and warfarin.